Hello, hello, everyone. Welcome. We're going to get started in about a minute or so. Welcome, welcome. Hi, Rick. All right, if you'd like, you can go ahead and get chatty and start putting your names and maybe your organization in the chat box if you'd like, just to say hello. We have a lot of friends, hopefully, who will join us today. And we're so very excited about our special guests. I mean, it's just going to be a really great conversation. So we're looking forward to it. So another minute or so to let our other colleagues come in and we'll get started.
Hello, this is Tasfai from Ethiopia. How are
Hello,
you?
hello. How are you?
How are you? Fine.
Thank you so much for joining us. Hi, Pedro.
Okay, thank you so much.
Hello, I've got some more. Oh, good. We have some more greetings in the chat. Take a look. Venezuela. Uganda. Albania. Welcome. All right. Take another half minute, Lindsay? Yeah. Get some more people in. We have some more folks coming in through the waiting room. Hello, hello. I see UK. Hello. All of our friends in the chat, just letting us know where you're coming from.
Hello.
Hello, John.
Yeah,
Yes, we can hear you.
From the CDC, Workforce Development Specialist.
Wonderful. Nice that you can join us. Thank you so much.
Yeah.
I will wait for Lindsay or Haley to give me the thumbs up when we're ready. Thank you. Thank you. I see Rhonda. Hello. All right. Okay, so I've gotten a thumbs up. I know we still have friends joining us, so I do want to make sure we get started because we want to make sure we have all of the time to hear from our special guests and so that we can also have a good conversation as relates to WASH and IPC. So as you know, we're in the land of Zoom. So I'm going to ask you if you could please go ahead and mute your mics unless you are ready to comment or ask a question, just so that we can keep the noise level a bit comfortable here. So as I was just saying, good morning, good afternoon, good evening to everyone. I want to welcome you to the WASH and Healthcare Facilities Community of Practice Initiative. We're so very pleased to have you join us today to discuss aligned agendas, developing effective WASH and infection prevention and control partnerships. I want to introduce myself and our team. I am Joanne McGriff, Assistant Professor within the Department of Global Health here at the Rollins School of Public Health at Emory University in Atlanta, Georgia. And I'm also core faculty within the Center for Global Safe Water, Sanitation, and Hygiene at Emory. I have with me, you've already heard me say her name, Lindsay Denny, also with the Rollins School of Public Health, as well as Haley Elling, who you already see in the chat, who's helping us with all manner of logistics and interpretation here. And so you'll see quite a few notes from Haley as we're moving through the webinar today. I'm going to begin today's session with a short reminder of what this community of practice is really about. So if I can have the next slide. So we are an action platform that brings together WASH and health communities to focus on evidence, policy and practice in WASH and healthcare facilities. Our goal really is to expand the conversation, connect the expertise and experience of our partners and colleagues to the members of the WASH community who have expressed interest in moving to action in WASH and healthcare facilities. We welcome all to participate in these webinars, whether you're a seasoned WASH or health expert on WASH and healthcare facilities. Oh, can I have you please mute? Okay, thank you so much. Whether you're a seasoned expert in WASH or health, or whether you've already been working WASH and healthcare facilities, or if this is just a brand new topic for you, everyone here is welcome. And we really hope to make these webinars interactive as much as possible so that we can share information and get to know each other. So you can see our main motto here is to connect, We do want to share, and then we want to encourage everyone to act. So next slide. I also want to remind everyone of the guiding principles of this community of practice. So you know where we're coming from in these webinars, or when you see one of our newsletters, you sort of know what our philosophy is. And the first one, and this really most relevant to today's webinar, is that WASH is a fundamental prerequisite for quality care within a healthcare facility, and that there cannot be effective infection prevention and control without adequate WASH. That is full stop, period. That is what we believe. And this is sort of the underlying theme of many of our webinars and the conversations that we have. The other one, number two, is WASH in healthcare facilities is a solvable issue, but it does require the action, the knowledge, the experience of multiple systems, sectors, and stakeholders that work together to see sustainable improvements. And then lastly, the community of practice is open to all. Everyone who wants to learn and share about their experiences, their knowledge, best practices. We welcome the diversity of perspective and experience here, and hopefully it is mirrored in the kind of presenters and the different kinds of topics that we talk about. So next slide. You know, I bring this up today, the team, we really felt strongly that before we go on and go further in our announcements, I'm sure many of you were as shocked as I was, as we were, yesterday upon hearing this devastating news of the loss of the global health legend, Paul Farmer. We thought it appropriate to bring up that we know that Dr. Farmer was a tireless advocate for health equity, for the poorest of the poor, and certainly on the issue of health as a human right. And you see a quote, one of many quotes, I'm sure many of you probably hold dear through his many writings and books explaining his approach to global health. We are so grateful for who he was, what he has done for global health, for Haiti, which is the country of my family, for Rwanda, and really for the globe in terms of his work and effort. And so we do honor him today, and just wanted to take this moment, if you will, to give us about 10 seconds and just a moment of silence in memory of Dr. Paul Farmer. Okay, thank you. Next slide, Lindsay. Right. What we want to do each and every time that we meet is, as varied as our experiences are, we want to make sure that everyone is aware of some success. And success can be a range of things as it relates to WASH in healthcare facilities, from small programs that are working on the community level all the way up to sort of global level announcements that we want to make sure you are aware of. And so for today, and also if you receive our newsletter, you should have already seen this particular project that was named within our newsletter as part of the Success Corner. So this is Catholic Relief Services, CRS, applying the clean clinic model for Catholic healthcare facilities in DRC during COVID. And so again, I'm not going to read the entire story. Again, if you have our newsletter, you'll see it. But basically, we saw over several months training of healthcare workers and cleaners, developing of WASH improvement action plans, providing direct support, and then providing consumables, which we all are very much aware of, especially if you're in the WASH community, in terms of the soap and disinfectants that are needed to keep appropriate environmental hygiene. And really the results being that it was a comprehensive and efficient WASH service delivery model that they essentially developed. And the oversight and support that was needed was greatly enhanced and improved. So I just wanted to draw your attention to the successes that are in the field as it relates to WASH in healthcare facilities. And hopefully, if you would like, or maybe you could reach out to CRS to understand about what they're doing in DRC and perhaps get more information about this particular project. Next slide. We also want to make sure each time that you're aware of any new publications or important resources as it relates to WASH in healthcare facilities. So we wanted to bring up this newly published report from WHO that is on the global analysis of healthcare waste in the context of COVID-19, status, impacts, and recommendations. And really, this is a document that quantifies the additional COVID-19 healthcare waste generated through UN procurement system. It describes current healthcare waste management systems and their deficiencies, and it also summarizes best practices. So this is really, really what's important for us in terms of having some opportunity to read and think about best practice as it relates to the reduction of waste, both human and environmental, human and medical waste as it relates to the impact on environmental health. So you can find it on the washinhcf.org/resource page, the WHO website, or you will find it in the follow-up email that we will send you as part of our practice here. Once every webinar ends, we send through our listserv a summary as well as the resources from each webinar. Next slide. Another publication, and you see the titles here, it says older, but newly available publication. This is coming out of Zambia's Ministry of Health, and it was posted in WashInHCF, again, .org, the resource section of the website, where it describes minimum standards, guidelines, SOPs, and it's basically the training manual that integrates IPC and WASH together, which is a fantastic opportunity to look through and see how WASH and IPC was conceptualized and how the two items were linked up in one manual for the Zambian Ministry of Health. So again, published in 2018, just posted last week, but we thought this is something that was incredibly relevant to what we're going to be talking about today. And with that, I'm going to go to the next slide and hand it over to Lindsay Denny, who's going to walk through, again, some of the thinking, rationale, and an introduction, if you will, to the idea and concept of aligning agendas, looking at WASH and IPC together. So with that, Lindsay, I will pass it over to you.
Great. Thank you so much, Joanne. And good morning, good afternoon to all. I'm excited to be having this conversation. This is something that I've really looked forward to and is one that I'm glad we have a reason to be focused on today. So I'll go ahead and get started. And again, this is just more to put everyone on the same page of where we're coming from approaching WASH and IPC. So complexities of WASH in healthcare facilities, it's an issue that falls between two sectors, between the WASH sector and the health sector. And these two sectors often work in parallel, but they may not directly work with one another. And so a conversation I have once upon a time had the health sector saying that WASH is responsible for WASH in healthcare facilities because of our technical expertise, and the WASH sector saying health is responsible because they own the healthcare facilities. So challenges in aligning because of this. And as you think about the two sectors working together and then specifically narrowing in within health on IPC, thinking about the fact that personnel often come from different backgrounds, but don't necessarily speak the same language. I think when we talk about this issue, we often hear this concern about a language barrier between the two. Both have skill sets that are necessary to create sustainable, safe WASH and healthcare facilities. But from the IPC side, we often see more of a clinical perspective, and WASH may be engineers or other WASH technical expertise. But when it comes down to it, we do recognize that there's an overlap between these two. This is how they work within the healthcare facility. And I often use the Venn diagram as an example of the overlap in which we see particular activities requiring both WASH services and IPC protocols. And so here I've highlighted the 4 key activities that I've identified. It may be different based on where you're working, but we look at hand hygiene, environmental cleanliness, and I include laundry in that as well, depending on the healthcare facility service level, medical equipment processing, and healthcare waste management. And to understand a bit about how we came to that, well, here's some photos of this first. So again, hand washing, equipment processing, environmental cleaning, and healthcare waste management. But a bit of background. So to first develop this and have these conversations, we were working in Cambodia at the time, and we opened the Cambodian National IPC guidelines and went through and looked at which of the topics that they were focused on required some level of WASH services. So as you see, I've highlighted here what we pulled out. And then we rearranged a little bit and named it a bit differently. But we looked at hand hygiene, appropriate handling of patient care equipment and soiled linen, environmental cleaning, and appropriate healthcare waste management. And so that is how we came up with this Venn diagram of different activities. But it's worth keeping in mind, I just wrote on there, sorry about that. It's worth keeping in mind different health services are provided at different types of healthcare facilities. Thus, the specific overlap that we talk about may differ if you're in a hospital providing surgical services versus a health center providing outpatient care. So again, for example, the laundry example may not be applicable when you're talking about outpatient care. This may also impact the organization and the management around IPC in the healthcare facility and that broader safety culture if you're at a tertiary healthcare facility versus a primary healthcare facility. So given this, saying that we've gone through the IPC guidelines and we recognize that certain IPC practices require wash services in order to be performed, then what are the implications of inadequate wash in healthcare facilities? And that's really the crux of what we want to get to today in the conversation around how we work together. Recognizing from the most recent report from WHO and UNICEF, though you could go further back, the JMP data demonstrates that we have a massive gap in wash services, particularly in least developed countries and places in facilities that have limited resources. And additional concerns that may not be included in the JMP, but may impact the ability of healthcare facilities to provide safe wash services would be water quantity, water quality, seasonality, whether or not there's seasonal availability of water, hygienic conditions, climate resiliency. All of these things add up to a picture of poor wash availability, which could impact the availability of, or the ability to practice IPC behaviors. And so this is really the thesis statement here. What we want to get to is why do we need IPC and WASH partnerships? There has been an assumption in IPC guidelines, particularly those guidelines that originated from well-resourced countries, that WASH services are readily available in healthcare facilities. But this overlooks the challenges that many facilities face where WASH services are either limited or entirely non-existent. And therefore, the IPC policies and guidelines are incomplete in these contexts, and healthcare facilities will struggle to ensure their staff can practice IPC protocols so long as the WASH services remain inadequate. And that's really our argument here as to why WASH and IPC need to be partnered. And why the disconnect. As you know, until very recently, there wasn't global data on this issue. Until 2015, there was not a report. The JMP had not looked into it in depth. But now we have sufficient data to tell us there are major gaps in WASH services. So now that we better understand the need, it's time to revisit this relationship between WASH and IPC in resource-limited settings. So what is the path forward? It's Emory's recommendation, and we'll hear from two IPC experts today to hear more about their thoughts, but our recommendation as integration as one path forward, ensuring that WASH is integrated into IPC strategies and agendas. And one great example over here from what we highlighted today is a 2018 document, but really a great example of WASH and IPC being considered in the same document and understood this way. It's not to say that they necessarily need to be done in this format, but thinking about them as integral, working together in terms of achieving safe quality healthcare. This may include determining the WASH services first to understand the gaps, then revisiting IPC standards and SOPs to think about how those gaps may influence the ability to perform these protocols, and then reducing barriers and inequities between the two sectors to improve coordination between the two. And just to note, again, they're overlapping sectors. So we recognize still that there'll be elements that WASH works on separately and IPC works on separately. But based on that Venn diagram, there is a significant overlap that is really important if we want to make sure that every patient receives safe quality care and every staff member who is at the facility is safe in performing their duties. So I'm going to stop there and just give you a few takeaways. Reminder here, WASH services are required for IPC activities, key IPC activities as identified, but often guidelines overlook the inadequacy of WASH services. Given the recent highlighted data and gaps, it's time to revisit this relationship and understand how we work together to address these realities. And again, we propose integration as a path forward to make this happen. So I'm going to stop there. I think it's time we hear from our speakers. So Joanne, I will hand back to you and you can do some introductions here.
Great, great. Thank you so much, Lindsay, for providing that background. And again, the perspective on integration. So it's now my pleasure to introduce, I will read out the bios for both speakers, but I believe it is Dr. Sade who will begin first. Okay, great. So as I just mentioned, Professor Sade Ogunsola is a professor of clinical microbiology at the College of Medicine, University of Lagos, Nigeria, and the director of the Center for Infection Control and Patient Safety. Her research interest and work has been centered mainly around the diagnosis and prevention of infectious diseases, infection control, and antibiotic resistance. She is the chair of the WHO Guideline Development Group for Ebola, board member of the Nigerian Society of Infection Control, and chair of the Infection Control African Network, known as ICANN, and has been involved in IPC for over 20 years. We also have with us Dr. Iman Huwedi, who is a fellow in clinical and chemical pathology, Faculty of Medicine in Ain Shams University, Cairo, Egypt. She has been a microbiology and IPC consultant since 2004 with extensive experience in infection prevention and control, both at the national and regional levels. She shared in supporting IPC programs in several countries, including Egypt, Pakistan, Iraq, Jordan, and Tunisia. At the international level, she has participated in reviewing WHO IPC manuals and has acknowledged in an acknowledgement for her efforts and commitment, Dr. Huwedi has been selected as a recipient of the 2019 International Scholarship of the International Federation of Infection Control, Infection Prevention and Control Canada Education Conference. So it is such a pleasure to have both of these speakers with us. And so without further delay, I will hand this over to Professor Sade Ogunsola to get us started. Professor, if you're with us, go ahead.
Thank you very much. Good afternoon, good morning, and good evening to everybody. I'm going to try and share my screen now.
Looks great, Professor Sade. You're on mute though, in case you're trying to get it going. Thank you.
Okay, can you hear me?
Yes, we can hear
Can you
you.
see
Go
my
ahead.
screen? Okay.
We can, if you
Thank
just
you.
put it in presenter mode. Yeah, there you go.
Yes,
Perfect.
thank you very much. First of all, it's a pleasure to be here, and I have tried to make this more of a conversation rather than an academic thing. So I'm going to go ahead just to remind us that from the IPC point of view, we see that WASH is essential for most aspects of IPC. Preventing contaminated water for drinking and healthcare, working with the hospital waste, preventing contamination of the community and the general and the and groundwater. WASH works with us in terms of the built environment, in environmental cleaning, sanitation, and aesthetics. And then in patient care, supporting most aspects of standard and transmission-based precautions. And then in the area of healthcare waste, just to bring us up to speed. So we see WASH as extremely fundamental to IPC. And if you look at the core components, it is a foundational part of the core components, creating an enabling environment for the prevention of disease transmission through the development of infrastructure for healthcare and supporting standard precautions in laundry, kitchen, waste management, hand hygiene, environmental cleaning, and the CSSD. It also helps us in supporting behavior change for IPC practitioners because it's part of the essential first step in our multimodal strategies, system change, to encourage behavior change. And then in terms of prevention of communicable diseases an AMR. The AMR Global Action Plan is very clear about improving sanitation, hygiene, and infection prevention. So I thought it would be great to hear directly from IPC practitioners. So I did a little survey of 18 tertiary institutions in Nigeria, asking 5 questions. Is there any group within, these are the tertiary institutions, we have about 36 in Nigeria. And so this is like 50%, and they're scattered all over Nigeria. So I said, is there any group self-identifying as WASH? If not, is there, who deals with your waste, infrastructure for water, sanitation and hygiene, works, your environmental? So I said, who does this? And then have you trained your WASH staff, whoever they might be, at your facility? And do you, as IPC, hold meetings with this group regularly? Are the meetings regular at team level, operational, or committee level, policy, or is it ad hoc as the need arises? So I decided to share a bit of the response because I think it will give us an idea. So do you have any WASH? 16 of the 18 did not have. It's not operating at WASH level. Then I said, who carries out this WASH? Most of them is the environmental sanitation group. Then about 6 of them, they say their works department. And then 2 of them actually said they have 2 WASH groups. But what was different was that these WASH groups were not located where the IPC team were. The IPC teams in these 2 hospitals were in clinical microbiology. The WASH were in community and public health. And one of the things they said is that they don't meet. And only 1 of them said they were part of their IPC. Then I said, any training for the WASH people in IPC? 4 of them said no. 8 of them said yes, but this yes was qualified. It was really around, well, when the need arises, and a lot of it from discussion was around COVID because they were in a response mood. And then 6 didn't respond. Then I said, what of meetings? Do you have meetings? 16 of them said, yes, we do have meetings. 2 said, no, not at all. So what are the type of meetings? 4 of them said, oh, we are together on the IPC committee level. 2 said, we're at the IPC team level. And 8 said, well, it's ad hoc. Whenever whenever there's a need for talking with them, they come in. If we have a problem, we have short meetings. And that these meetings invariably maybe once or twice a year. So essentially, there wasn't any standard regular meetings. So these are some of their voices. We don't have WASH. Waste management is undertaken by environmental sanitation. Toilet is by plumbing unit, and IPC conducts training occasionally. Oh, we don't call them the WASH team, but the environmental sanitation team. They oversee water, sanitation, hygiene in the hospital. They're different from the IPC team. The maintenance department is also involved. No formal training for WASH team and what they do is not acceptable. So they recognize that it didn't work, but nobody had taken any initiative to make it better. We have the IPC committee and an environmental sanitation committee separate. They handle WASH, but we do have joint meetings occasionally. They're not statutory, mainly ad hoc. And this was essentially the WASH unit, works department members. So WASH is even divided amongst departments. It's broken up. And even sometimes with private sector, a cleaning company oversees and deals with water, toilet, and waste matters. And I went on, in general, this was, only one said, oh, no WASH unit, toilets and waste management is on the environmental unit. They are key stakeholders of the unit and are members of our IPC and present in our regular IPC meetings. They are resource persons when we do hospital-wide training on waste management. They're quite informed. And so we had 1 or 2 of these, and it was important to hear what they were doing better to get a sense of how do we come in and bring them closer together and what was mitigating against this. So in general, the what were our key findings? Well, that there was interaction with WASH often at IPC committee level, which is a policy level, but there was really little interaction at the level of the team, which is at the operational level, except as maintenance. Most WASH activities are fragmented between different units, and then IPC WASH still siloed. Of all this, sanitation was the most misunderstood. They just saw the WASH as repairing their toilets. It was more about convenience, certainly not about health. So when we had these discussions, we came out with the idea that, yeah, IPC practitioners, we need WASH and the WASH needs us, but they were not, they were a bit more hesitant about how do we bridge the gap. So how do we move forward to achieve that vision of global action plan, of having by 2030, which is just around the corner? I looked at the task team and we said, at advocacy at the healthcare facility, one of the things we all have as low-income countries are that the WASH problems are issues that hospitals they don't prioritize. IPC is not prioritized. So if we work together in advocacy to advocate to our healthcare facility managers, we would get much further. One or two of them who did this, especially during the COVID, said they got things out faster than when they had gone individually. Now, in terms of the evidence and operational research and the policy standards and facility improvements, once this is being done, which is usually by IPC, WASH colleagues should be brought in at the beginning so that we're working together at all levels. And we're also ensuring that we understand what is happening in our facilities. This is because we can't imagine it. They know the issues they have to deal with so that our response and our gaps are real and our solutions are doable. So how do we move forward? We should have a WASH person on the IPC team at operational level. Normally, we just talk about the IPC nurse, the IPC doctor, you can have somebody from the lab. We must have somebody from WASH on that team because the issues of IPC in low and medium income countries, a lot of the problems are because of WASH. Then we have to have WASH to have an IPC person on their monitoring meetings and visits. There must be intentional training on IPC for WASH people, and IPC practitioners must be trained on WASH requirements. They must follow following the WHO standards, WASH fit, etc. And to interpret and adapt to their local conditions. Then at ICANN, we have an IPC WASH training, which is a joint training of IPC practitioners. Just a slide on that. So you can see joint collaboration in writing guidelines and SOPs. So ICANN can support this effort. We formed the IPC WASH working group, which is responsible for communicating amongst themselves and supporting themselves. They work together on presenting scientific papers and advising ICANN on WASH. They have plans for supporting country-based training to bring IPC and WASH people together. We have linked them with the engineers, and ICANN at its own level is also linked with the South African Federation of Hospital Engineers, SAFI. Last year, we had our first joint conference, and we're having another one this year. So this collaboration is to continuously bring us together, and ICANN works at the grassroots. We work with country associations. And we work with nurses and doctors and lab that are in IPC at the grassroots. So bringing all these groups together, for us at ICANN, it's now IPC WASH. They're totally interlinked. And then we have a train the trainer course that will enhance the teaching abilities with the IPC WASH community using evidence-based training curriculum. Presently, we're looking for more funding to be able to carry this out even more, but it will be done. But one thing that's unique about it is that we train both the IPC practitioners and the WASH community together. And we have really robust conditions and increased respect for each other. And I think we start to break the language barrier. So I think on that note, I just remind us all of the benefits of WASH to IPC. I think those of us in IPC need to recognize even better the value of WASH to IPC. We say it, it's probably more obvious at national levels, but at the facility level, there's still a lot of work to be done for us to translate what we say into action. Thank you very much.
Thank you, Professor Sade Angunsola. We so appreciate this presentation. And just so that we can save all of our questions and thoughts for after the presenters, I'm going to invite Dr. Iman Huwaidi to go ahead. If Dr. Sade, if you can go ahead and stop sharing so that we can have Huwaidi start sharing. Yes, perfect. Thank you so much. Dr. Huwaidi, I'll hand it over to you.
Thank you. I'm really happy to be with you today. I enjoyed all the presentations, by the way. I'm here with the hat of the IPC team, from the IPC team point of view. I want to show you how we, as an IPC practitioner, can work and with the WASH team, because one of our core activities in IPC and to apply the safe care is having a safe WASH service. Otherwise, it will not work. By the way, I want to say good morning, good afternoon, good evening, everybody. I'm happy that I saw that there is more than 100 participants across the globe, I'm sure. Let me to share my screen. Give me 1 minute, please. Share it. Share the PDF file. I don't know whether it is.
We're seeing a folder and not the
Folder, yeah?
Mm-hmm.
I will try to share it right now. 1 minute. Couldn't see it.
If you'd like, I can share it for you if that's helpful.
Yeah, please share it from your side. I found it here, but I will share the PDF because I couldn't find the presentation itself. I will share the PDF. Yeah, it's okay. Thank you, Neil. So here we can, we have, it is like much more a discussion, like Dr. Shadi said, that we want to see the alignment, how we are as an IPC people can work with the WASH team in order to provide a safe healthcare. Please, next. I think that not all of you are IPC professionals or know a lot about IPC. So I would like to give a summary or a rapid summary of WHO core components of IPC program that must be present at the healthcare facility level, because among these core components, we have the core component number 8. It is a whole core component that recommends that we should have a WASH service and a good implemented WASH service in the healthcare facility in order to ensure implementation of good IPC practices. I would provide you with some highlights about the recent publication that is published by the WHO as regards the WASH and as regards the IPC in the context of COVID-19 and how both of them are integrated together to provide the safest care for the patient, for the health worker, and everyone present at the healthcare facility. Then I want to discuss with you rapidly, even in my hospital, what is the role or what is my role in IPC as regards the WASH, and how we can integrate our effort as an IPC team with our on the ground. And we want to discuss together also ways of communication and linkage between the IPC and WASH services, how they can meet, when they can meet, how they can coordinate and communicate together to push the wheel forward. Next, please. This is some important figures which provide us with some burden of HAI that present around the globe. We can say that among 1 in 10 patients get an infection while receiving care. More than 50% of surgical site infection can be antimicrobial resistance. I'm sure that this figure is much more higher in the context of the current COVID pandemic. We know that there is a huge consumption of antibiotic over there, which we are facing a real challenge as regard the AMR present around with no antibiotic working enough. And the only salvage for this problem is the IPC and WASH service. Actually, we can say that we are a little bit lucky that presence of IPC program, an effective and efficient program, can prevent 30% of HAI in healthcare facilities. And of course, all of us know that the healthcare associated infection have a very challenging burden over the general health. It causes more serious illness, prolongation of a stay in a healthcare facility, long-term disability, excess deaths, high additional financial burden, high personal cost on patients and their families, and healthcare associated infection are complicated by AMR, as I previously said. But as long as, next please, as long as we have an efficient infection control program in place, we can overcome the burden of HAI. Infection control program is a scientific approach. It is a science, practical solution designed to prevent harm caused by infections to patients and healthcare workers, grounded in principles of infectious disease, epidemiology, social science, and health system strengthening, and rooted in patient safety and health service quality. Next, please. Actually, if enormous situation, IPC is important, but IPC requirement in facing the outbreak and in facing the current outbreak, like the current pandemic of COVID-19, becoming much more important. And most of us see this across the globe, whether in high-income country or low and middle-income country. Once the hospital or the healthcare facility or the country have an efficient IPC program in place, the burden of COVID-19 in the facility and at the healthcare worker and the losses become much more decreased. So now, after the COVID-19 pandemic, it showed that IPC is crucial for the resilience healthcare system. Without IPC, there will be no quality. We couldn't provide a quality of care for our patients. IPC is ongoing activity. It is not related to pandemic or current or outbreaks. It is ongoing activity to prevent further outbreak, undertaken by the national program and by IPC focal point team and committee, the healthcare facility senior management officials, and all staff at the facility level. As we always say, as IPC people, we say that IPC is everyone's business. It is not our business. It is everyone's business. IPC is crucial in response to epidemics, to reduce the transmission of infection to staff, patient, and visitor, safe provision of care, and rapidly identify healthcare transmission to protect the healthcare worker and contain outbreak before they spread. Next, please. So the goal of IPC is protecting everyone, protecting yourself, your patient, family, and the whole community. Next, please. And actually, the WHO published a guidelines called Core Components of IPC Program at the national and acute healthcare facility level that is published at 217. These guidelines act as a roadmap to indicate how IPC can effectively implement it to prevent harm due to healthcare associated infection and AMR. Implementation include effective leadership and multidisciplinary team to translate guidelines into practice. And under the word multidisciplinary team, I put millions and millions of lines, because the IPC cannot be implemented with the IPC people alone. We need a multidisciplinary team. We need the WASH team, the engineering, the hospital managers, everyone work with us to implement the safe care for the patient. Next, please. These core components, actually, they are 6 at the national level and 8 at the healthcare facility level. They are building blocks of IPC that should be present in place in order to ensure that we have an effective IPC program. These core components are evidence-based, and 3 of them have a good practice statement. Next, please, which is the most much importance for today, is core component number 8, which is related to the built environment, materials, and equipment for IPC facility level. This core component highlight the importance of WASH service to ensure implementation of IPC program and practices at healthcare facility level. At the facility level, patient care activity should be undertaken in a clean and or hygienic environment that facilitate practice related to the prevention and control of healthcare associated infection, as well as AMR, including all elements around the WASH infrastructure and services and the availability of appropriate IPC materials and equipment. At the facility level, materials and equipment to perform appropriate hand hygiene should be readily available at the point of care. This is based, as I told you, on evidence-based practices, on good statement practices that ensure that appropriate and clean hygienic environment, WASH services, and material and equipment for IPC, in particular for hand hygiene, is essential and crucial to implement a good IPC practice in any healthcare facility. Next, please. While we are discussing and preparing for the session, actually, Danny told me or asked me, whether do you have, as an IPC people, some tools that we can use as a WASH people to assess the services or WASH services? We have too many tools. One of them is the IPCAF tool. It is a WHO published tool, standardized tool that assesses the 8 core components of IPC that should be present at the healthcare facility level. As I told you, core component number 8, which include the WASH services and other related services to build environment like the ventilation and whatsoever, can be assessed by this tool. As regard the water services, the quality of water, the sinks of hand hygiene and the facilities of hand hygiene, and the supplies for environmental cleaning and waste management, all of this is included in the IPCAF tool to assess core component number 8 related to built environment of healthcare facilities. Next, please. So, WASH, in the context of COVID-19, WHO published huge number of technical guidance. Some of them related to the IPC, some of them related on WASH, and the most recent guidance combine both, because both of them cannot work in a separate way. They have to work together. The first guidance published for WASH sanitation and hygiene, it was published by the UNICEF in cooperation with the WHO. It was published in July 2020, and the latest guidance for IPC in the context of COVID is published in July 2021. They may be the most recent guidance include also the recommendation involved in the guidance for WASH. Let us see what is the most important recommendation present in each of these guidance. Next, please. So the most important recommendation that come in the wash, sanitation and hygiene and waste management guidance that is published in July 2020 is that we have to focus on hand hygiene. Frequent and effective hand hygiene is one of the most important preventive measure as a right time and right technique. Environmental hygiene, effective inactivation on surfaces can be achieved within 1 minute using common disinfectant. Existing WHO guidance on the safe management of drinking water and sanitation services apply to the COVID-19 outbreak. WASH investment should be fundamental to all countries' preparedness and response plans, and co-benefits. Many will be realized through good WASH, including preventing millions of deaths each year caused by other infectious disease. Let us see what is recommended in the IPC guidance in the context of COVID-19 to prevent further transmission. Next, please. These guidelines summarize or recommend 5 main recommendations to prevent transmission of COVID. First of all, applying standard precautions for all patients all time, ensuring triage, early recognition and source control, empirical addition precaution for suspected COVID cases of COVID-19. That is to say, once I suspect or diagnose patient with COVID-19, I should add additional contact and droplet precaution, wearing gloves, wearing mask, and this type of precaution. Administrative control and environmental and engineering control that focus mainly on WASH service. If we look at the standard precautions are sets of IPC precautions that should be applied for all the patient all the time, whether they are infected or not. Once the patient is coming to the hospital for any purpose, the doctor or the nurse or whoever will provide the care for the patient should follow this set of standard precautions in order to prevent transmission of infection for themselves and for other patients. Let us, there are about 7 items that should be all of them present in place to ensure a safe environment and a safe patient care. They are hand hygiene, respiratory hygiene, use of appropriate personal protective equipment according to the risk assessment, injection safety practice, safe waste management, proper linen, environmental cleaning, and sterilization. So, if we look at these precautions or the standard precautions, the essential package of precautions that should be placed in every hospital to prevent infection. Does WASH play a role in any of them? Actually, I was very excited by Venn diagram in the first presentation when show how that select some precautions or some of these precautions and show how the WASH surface can play role of them, like the hand hygiene, environmental cleaning, waste management, and whatsoever, and the sterilization of instrument. In my opinion, WASH surface play a role in all the standard precautions items present. Of course, for the respiratory hygiene, if I do coughing or something like that, I will perform hand hygiene after that. If I will use personal protective equipment and getting them out, I will perform hand hygiene. Environmental cleaning, it goes without saying, I have to have a good WASH services to provide the adequate amount and the adequate quality of water supply. Injection safety practice, I need water and I need the hygienic environment in order to be sure that all the injections are safe. Safe waste management. Of course, it is one of the fundamentals of waste of WASH. Proper linen, the reprocessing of linen need a good quality of water and safe water supply. Environmental cleaning, all of us agree it is one of the crucial elements related to the WASH, and sterilization and reprocessing of medical instruments. So WASH services play a role in all precautions of IPC, not 4 of them, not 3 of them. Next, please.
Dr. Hawedi, if we can ask that you begin to bring your comments to a close for us.
You want me to receive some comments?
No, if you would, due to time, we want to make sure that people have plenty of time to reflect and ask questions. So if you would.
Yeah, I think that I will finish this slide, then we can open the discussion. It's okay?
Perfect, perfect. Thank you.
Yeah, welcome. So as an IPC, how we can support the wash services at healthcare facilities? This is such an example. We should ensure that the appropriate infrastructure in place as regards the number and distribution of hand washing sinks and functional toilet. We are not focused only on numbers. The distribution is important. How far from the point of care? How is the access is easy to reach the hand washing sinks? The material and finishing of sinks and the waste products and whatsoever. The storage and final treatment of medical waste. As an IPC expert, we have an expert opinion in this. IPC precautions during construction and renovation. During the construction and renovation related to wash services, we have a special precaution as an IPC, how to protect the environment, how to protect the patient and whatsoever. We have an expert opinion in the supplies, whether they are enough and appropriate supply related to the environmental cleaning, the hand hygiene, the waste disposal, and the personal protective equipment that will be used by the workers and those who work on wash. The water quality. We need to check the water quality in high-risk areas like the dialysis unit, endoscopy unit, and the surgical suite. The drafting the SOPs related to the wash services regarding the minimization of waste, of the medical waste or segregation of medical waste or the environmental cleaning, education and training, and doing regular monitoring and feedback in order to identify gap and replenish our plan, and doing this monitoring tour and audit tour organized and coordinated with the wash service. Next, please, and the coming slide is the final one. So how we can communicate with our wash colleague. In each of our facility, we have an IPC committee. It is a multidisciplinary committee. We should invite our wash colleague in this committee. We should encourage coordinated audit tool between the wash and IPC services. We should share reports and provide regular feedback. For here, I will finish. And we will start open the discussion and taking the comment. Thank you.
Perfect, Dr. Hawedi. Thank you so very much for this excellent presentation. I also thank Dr. Sadia Gonsola for the presentation before. And so now I think we come to the time where we would really like to have another member of our community, Molly Patrick, environmental engineer on the International Infection Control program at the US CDC. If Molly, you can just get us started by maybe reflecting on some of the points that have been raised by Professor Aguinsola, as well as Dr. Hawedi. I also see there are a number of chat comments that have been coming in, specifically working together in IPC and WASH. I think we need to have Dr. Hawedi go on mute if possible. Yes, perfect. Thank you. If we can have Molly Patrick just give us a few comments, that would be wonderful. Molly.
Yeah, thanks so much, Joanne. Thanks to all the presenters and for you guys for organizing this. So interesting, such an important discussion. So yeah, I was sort of thinking about, so I am a WASH person working on an IPC team, and I have been for a number of years, but I was sort of thinking back in some of the kind of early lessons that I learned when I was switching over from that, WASH to IPC space. And a couple of things came to mind that I thought I could just, briefly share to start the discussion and then maybe offer maybe a potential solution. And I think a lot of this is echoing what we've heard already today. So the first thing I can remember is really that I hadn't fully appreciated just how clinical IPC is when I started. Most of the people on my team are clinicians. And their focus is really patient-centered, really very much on the practices that are performed during patient care. So I think because of that focus, it's true, as we've said, that it really does tend to, I think, inadvertently overlook WASH and the supporting infrastructure and services that are needed to be able to perform those practices. And I think that that's related to the resource level issue that Lindsay brought up, but I think it's just a factor of the focus being so much on the patient that, I think the WASH stuff just feels really peripheral and really not on people's radars. So, oh, sorry, I'll come on video. I think as far as a solution to that, I mean, again, I think what the speakers have said, which, I obviously believe in because I'm here on the WASH team, but I really think, it's really important for WASH to be at the table. And, really in my position, I'm able to be there full time and, offer that WASH perspective and inputs on things on, a day-to-day basis, which I think makes all the difference because it's just really not on people's radars. It's not that they don't think it's important. It's just that the orientation of the field is really on the patient. So it's kind of just outside of their field of view. The second thing I can remember that I think is important for the WASH community to think about is that I remember coming to realize very early on just how little I knew about IPC and HAIs when I joined. I thought I knew some things, but realized very quickly that I knew nothing. It's a huge field. Healthcare is really different, different bugs, different modes of transmission, different types of infections than what we're used to in WASH. So I think that realization for me early on was sort of a wake-up call that, if I wanted to bring WASH to the table and really advocate for the importance of WASH to prevent infections, I think one of the first things that I had to do was really learn more about, what those infections were and how they're transmitted. And I think that sort of gets to the speaking the same language issue. And it's really taken time. I think I still only really speak basic IPC. I've been on an IPC team for 5 years, but yeah, so I really, my plug and my perspective now, I think is really on multidisciplinary teams. So really, truly integrated teams. If you're on the call and you're a WASH program, consider hiring an IPC specialist full-time. Likewise, if you're an IPC program, hire a WASH specialist actually to your team. I think you can have really good collaboration and communication structures, but I don't think that it's comparable to the potential benefit of actually having a truly integrated team, where you're always sitting around the same table, you're able to learn the same language. So yeah, I think that's sort of my plug. I know that it can be hard structurally to do that, but it's CDC is very siloed and we've been able to do it at CDC. So just a plug for people to think about in their own organization. So I'll stop there. Thanks.
Great. Thank you so much, Molly. And again, I see there is lots of kind of comments in the chat. I will say, please, if you have any questions or issues you'd like to raise, either raise your hand and we will ask you to unmute yourself, or if you have a question, go ahead and place it in the chat. I know there was one from Maggie about if anyone could talk a bit about how WASH and IPC partners are collaborating on the ground to improve action, monitoring, resourcing, advocacy for these areas. If anyone has experience or would like to speak to that of any of the panelists or speakers, please go ahead. But otherwise, again, I encourage you to drop your questions in and we will keep moving with the discussion. And I think this is the reason why we knew this session needed to be 1 hour and 15 minutes because we had such great presenters and we knew they had such important information to share with you, but that we needed just a few more minutes to be able to ask some questions and have discussion. So this is our moment in this last 15 minutes to do so. So I'm going to go ahead and pause and see if any of the speakers would like to talk about any of known action in terms of collaboration between WASH and IPC groups here. I think, did we lose Professor Gonsola?
Sorry. No,
There you
I
are.
was going to make another comment. So I sort of stopped because it wasn't about the international collaboration. But just to, I think one thing that keeps coming through is that we have a lot of the integration on paper, but what what comes through when you're talking to the IPC people about the WASH people, oftentimes on the ground. One, I'll just speak for Nigeria. I think countries are different, but I think we're bad in that sense. We're far, was a sense that the WASH people are just there to do maintenance, and it wasn't, and you found that issues of WASH were not in one place. So there were like 4 different people dealing with different things. So it wasn't cohesive. We've just done an environmental cleaning program, and Molly knows this. And we found even the cleaning was broken up into pieces. Somebody was in charge of those who were in-house, somebody was in charge of, so there was no real cohesion. However, they do have somebody on their IPC committee team, but a lot of IPC committees don't function too well in low and medium income countries. So we need to have closer collaboration on a sort of day-to-day basis for them to understand. This happened when we were doing a renovation of our CSSD, bringing in the engineers to talk with the IPC and the other healthcare workers was such an eye-opener for them, and was for us also an eye-opener in the sense that we realized the possibilities and the things we could achieve just by working with them on a day-to-day basis. And that changed a lot of things. So I think one of the things the integration should be closer than the IPC committee, which tends to meet maybe 4 times a year. We need to have more daily sort of integration if we're going to really change behavior and change mindsets. There's a lot of mindset issues here on both sides at the facility level. Some people have done well, but where it's not going on too well, there needs to be more talking together and working together. Thank you.
Excellent points, Professor Ogunsala. Thank you so much for that. Again, as we're I see there's some questions that are coming in. I was wondering, Lindsay, if this would be a good time for us to ask the community of people who are here with us a few questions, just to get a sense of who is among us as it relates to this issue of WASH and IPC. I'm sorry, do I see Dr. Houedi who would like to make a comment before I?
Yeah, thank you.
Go ahead, please.
I think that, I think I totally agree with Dr. Shadi. That is, we need some sort of closer integration, maybe like we need policies, we need SOBs, we need like the programs with well-defined responsibility for each of the teams, who will do what. And we may experience some sort of, in one of the renovation of our surgical units, that the engineering and the WASH services began their work. But when we start the process and we are seeking accreditation, we find that most of the standards are not applied for the accreditation body that we are seeking for. So we revise the work once more, and we double the cost if we integrated the effort from the start. And the integration will save will save a lot. Will save the cost, will save the time, and will provide the best service that should be in place. Thank you, and over to you.
Great, thank you, Dr. Houedi. We do have another question, so let me divert a bit back to the chat because some questions are coming in now. We have one from Isaac, I believe, talking about the way forward at the facility level. One of the speakers made mention of international training on IPC for WASH. Are there international protocols? How do we integrate those protocols at the local level, since there is a difference in facility infrastructure, structure, and practices? So if any one of our speakers, or perhaps a commentator, Molly, if you'd like to take a shot at this question. Dr. Houedi, are you wanting to speak further? You're on mute.
Actually, I think if I get the perspective from the question is that the guidelines may be differ or covering or having recommendations that addressing the the healthcare facility with a certain type of resources or high level of resources. But let me tell you about something that as WHO published the whole core components for IPC, also publish the minimum requirement of this core component. It is not an issue to have all the core component in place or the IPC, the full IPC program should be implemented in place. But according to the resources present, and the resources by the way, it is not only the budget or the money, the human resources, it is an important perspective to look at. We have a minimum core component or a minimum requirement that should be present in place, not less than this minimum to be present. So the guidelines is like it has the full recommendation that they have that look at the countries or the healthcare facilities with a good resources. We also have recommendation that is, it is a minimum, but it will not affect or breach the safety. I think that we have sets of minimum requirements that can be applied and to be in place, and it will not also breach the safety. Thank you, and over to you.
Great, Dr. Houedi. In fact, if we can just pause for just 1 second, I know people are going to need to start to leave us. We'd like to ask the community just a couple of questions through a poll on Zoom. So Lindsay, if you would, yeah, here we go. So if you would just take a few moments, this is anonymous, to answer a few questions for us in terms of, do you agree with the notion that there is a need to integrate WASH and IPC in healthcare settings? Second question, are you currently working in what would be considered effective WASH IPC partnerships? And if you are, we're going to want to hear from you. And then the third question is, what are the barriers to effective WASH and IPC partnerships that you may have experienced? And you see some options here, but then we also have the last option is other. So if none of the ones above fit you, and if you click other, we'd like for you to just go ahead and drop a few comments in the chat as to what are the kind of barriers that you have experienced, because I think this could be something that we can all reflect on during this session for the last few moments. So go ahead, take about 30 seconds, if you will, and complete this poll for us, and then we'll show some results to know sort of who we have among us here.
And for that last question, you can choose multiple responses. So there may be multiple barriers you've faced in this work, whether you're the IPC person or you're the WASH person. So interested in both ways. And as we're doing this, actually, just want to highlight what Maggie Montgomery just put in the chat, because you were absolutely correct, Dr. Montgomery. We are all suffering from a lack of resources. And so I think there is also something said about collective action. And as we think about integrating, how do we become stronger by building each other up and demonstrating that we are both necessary for the safe provision of health services?
Thank you, Garance. I already see a comment on some of the barriers. If we take another 10 seconds on that poll, if we can flash up the results in the last few moments.
Yeah, give folks just one more second here, about 50% of respondents. So just take a minute. All right, I will go ahead and close the poll in 3, 2, 1. And let me just share the results. And you can see it, Joanne?
Okay, I can. Thank you so much. Hopefully you all can see it as well. And so, oh, I just
again. That box at the same
there
time.
There we go. Okay, great. So I think we can all agree, it looks like at least 97% of the ones who answered the poll agree that we do need to integrate. So that is very good to know. The second question about, are you currently working in effective partnerships? 42% of you say yes, 38% think somewhat, and 20% a resounding no. So again, this webinar and all the things that we're talking about right now is really such an important moment and opportunity here to figure out how do we begin to work more effectively? What is that language barrier, et cetera? And then here, in terms of a nice spread here, in terms of feedback on the potential barriers, 20% feel like the contacts are not as adequate or not sure who to contact. 43% acknowledges poor communication. 55% acknowledge the different agenda and goals. Almost 60% different funding priorities, which is the comment that Lindsay was just raising as it relates to the chat comment. And then there was some other, and I know we started to see some comments in the chat in terms of other barriers. About AMR being viewed as an issue of lack of medicines and not recognizing that it does have links to environmental conditions such as wastewater and what we're doing with it, and then the weak IPC structure. So again, so much more to talk about. I think we probably needed 30 minutes to have our discussion and opportunity to hear from our excellent presenters and speakers. I do want to thank Dr. Angunsela. I do want to thank Dr. Hawadi and also Molly Patrick from US CDC for their sharing their thoughts and reflections. I realize we have exactly 1 minute before we need to close, and I realize that Lindsay does need to go over just some final comments before we close out, but I do thank our great presenters, and I hope we can continue this conversation, whether it's within conferences, online, and certainly if you want to email us to contact us, which Lindsay's going to tell you about. So go ahead, Lindsay.
Great. So actually, I'm going to drop down to part 3 here, nominated success story. 27 of you said that you work in effective IPC and WASH partnerships. We want to hear about that. We want to share your story. We want to know what worked, what was successful, what you're excited about. So please, please, please send us an email. Haley, can you drop our email in the chat? WINHCF action@emory.edu, WASH and HCF action@emory.edu. So in addition to nominating a success story, you can join the listserv. We can drop that back in the chat, and you can also send us topic recommendations. What do you want to talk about? What do you want to discuss like we did today? And then last but not least, if you haven't yet, go to washandhcf.org/COP for, you can find the recordings of this. You can find all the information. Also, go to washandhcf.org/resources. That is where we talked about all of those resources today. They're all up there. You can see all of these and more. Please be using that website. It's a fantastic resource, and it has so much more than just what we've scratched the surface on today. So I'll go ahead and close there. 1 minute past. Apologies for taking up extra time, but very exciting. Great to have you all with us today. And certainly we'll be back in touch. Our next live event will be in April, and we'll talk about operations and maintenance for WASH and healthcare facilities. So thank you again. And thank you, our translators. You all are fantastic. Have a wonderful day.
Thank you all. Thank you so much. We look forward to seeing you in April.
And we'll keep the room open a second if you want to write any more in the chat. Thank you all.
And Haley dropped all those links to the website, to the listserv. All the links are in the chat.
Thanks all. Take care.
Goodbye, everyone.